So now we're going to move on to talking about what is and, excuse me, used to be and probably still is my favorite opioid in the world, Remifentanil. And those in neuroanesthesia through the 90s on saw that Remifentanil really took hold in our specialty. And today I'm going to spend a little bit of time talking about, does Remifentanil meet the criteria to be essential for neuroanesthesiology? I've got no disclosures, no financial relationships with any industrial companies. When I talk about anesthetics, though, what I really like to compare it to is local recipes. I didn't have the heart to put a bunch of different poutine recipes up there, so today we'll talk about cookies in general because everybody likes sweets, I think. Today we'll go over some of the goals of anesthesia for intracranial surgery, talk about Remifentanil's emergence in intracranial surgery and how and why it became a dominant opioid for a lot of anesthetics. Talk about the non-opioid alternatives that our previous two speakers have talked about some, and then also the future considerations. I'm not going to be talking about awake craniotomies that need speech mapping of the cortex because I think that's a very special and different population. I won't be talking about spine surgery today because I think those data are a lot more complex than what we think about for intracranial surgery and opioid use. And finally, the pharmacoeconomics of using opioids or using Remifentanil or other drugs I'm not going to talk about. But as as our previous speaker said, the goals of anesthesia, or in this case neuroanesthesia, are amnesia and hypnosis fundamentally, and then anti-nociceptive activities that would provide immobility if you're not using muscle relaxant drugs, or hemodynamic stability from when the incision is made, the Mayfield head fixation is placed, or even the bone is drilled. We also look at things that will provide cerebral autoregulation and not inhibit it, like the high-dose vapors will. We would like to see neuroprotection, or at least not neurotoxicity or a neutral effect on neural outcomes. Neuromonitoring is something that I think the younger surgeons are using more and more frequently. And finally, the fundamental thing that we always are going to get judged on for neuroanesthesia or intracranial surgery is rapid emergence. If the patient doesn't wake up quickly, then your surgeon just kind of starts looking at you and saying, what's going on? And I think that's one of the hardest things I find as I experiment and tinker with different anesthetic drug combinations is how do I provide as good of a wake up with intolerance of my surgeon before they say, don't do that ever again. Now, the ideal opioids for neuroanesthesia, really, if you think about context-sensitive decrement times, this is the time it takes for a 50% drop in the plasma or effect site concentration, and this is the infusion duration minutes. You can see Remifentanil just blows everything out of the water. Fentanyl, alfentanil, sufentanil take on the order of 10 to 100 minutes for the average 4 to 6 hour craniotomy in the larger skull-based population. And yet Remifentanil has a flat context-sensitive decrement time that is on the order of 10 minutes or less. This means it's predictable. And if you look at Remifentanil, even in the high doses where you need 75% drop in its concentration, it's still under 10 minutes and predictable. If you look at the anesthetic depth requirements for intracranial surgery, this is a cartoon that Ira Rampel showed me, gosh, in 1993. And in minutes of surgery, going up to 330 minutes, so we were at UCSF and it was a little bit of a slower resident institution. And on the y-axis, you see a categorical stimulation intensity, 5 being the stimulation of direct laryngoscopy from a hemodynamic or nociceptive point of view, and 0 being no stimulation at all. You can see after induction of direct laryngoscopy, then induction anesthesia, and then you've got this drop-off that you're sitting here putting in your lines and positioning. You place a Mayfield head fixation and have a brief 5 to 10 minute stimulation of hemodynamics. And then you have all the positioning related, nothing going on, low intensity except for the endotracheal tube and the baseline stimulation of the Mayfield fixation device. Then they start their incision, have an opening, and that's stimulating. They get intradural, and because once you're intradural, there's no sensation of the cortex and subcortical structures that are not durally innervated. You've got same baseline stimulation of just having an endotracheal tube and Mayfield pins on. When they start closing the dura, you have stimulation again. They start closing the muscle and skin, you have more stimulation, and then they take off the pins, and you have a patient who needs very little analgesia at the end. At least that's our typical concept of how we do anesthesia for craniotomy. Well, how do you choose your opioids? Well, when you're cooking or making chocolate chips, you got to think of what kind of chocolate chip you like. And if you are a Remifentanil fan, you probably like the dark chocolate chips. And I'm going to be biased and say if you don't like any opioids at all, you're going to like what they call white chocolate. But I don't mean to offend anybody here about which chocolates are their favorite. If you look at the literature in the 90s when the synthetic opioids of alfentanil and sufentanil started to gain favor and started to make its way into our recipes, and fentanyl had been along for at least 10 to 15 years by now. What you found is that if you do titrated, quote, equal analgesic doses in a blinded fashion, you can still provide equal analgesia and equal intraoperative, I should say, equal anti-nociceptive and hemodynamic stability by using all three of those synthetic opioids, alfentanil, fentanyl, and sufentanil. And this is just a pharmacokinetic simulation showing if we were using the doses that they reported in this randomized controlled it was a double-blinded study, what the concentrations would be and how they all mimic each other with a little bit of that the fentanyl is on the higher side of the concentrations and the alfentanil is on the lower and sufentanil is in the middle. Remifentanil, if you look at the first randomized clinical trial of remifentanil in craniotomies, you find that remifentanil made all the peaks and valleys disappear because you could just dose it up front and then start your infusion and then keep your infusion go up a little bit and when they made skin incision, maybe go down a little bit for intradural, up a little bit for bone flap being on and turn it off for pins, and you had a rapid emergence. You could see that fentanyl, you had to be lower the whole time and you were titrating. If you look at how I did my typical craniotomies in the late 90s and most of 2000 to 2015, if I did fentanyl, which I did do occasionally to teach the residents how to not use remifentanil, I loaded with 2 loading doses of 5 mics per kilo each, one for induction and the second by the time about 5 minutes before the Mayfield pins were placed. And then I started infusion about 2 mics per kilo per minute. And once it got intradural, I went to 1 mic per kilo per minute. When they started closing, I turned off my infusion. You can see the decay of the fentanyl. Whereas remifentanil, I could do almost whatever I wanted. In this case, I was running 0.15 mics per kilo per minute for incision, dropped to 0.1 for intradural, and went to 0.125 for bone flap being placed. But again, it's a rapid, predictable when I turn it off. The key thing, and this is something that Dr. Mao had brought up also, is that when you're looking at opioids in intracranial surgery or any surgery, for remifentanil, the thing that you have to remember is that you need a transitional opioid. If all you're doing is using remifentanil, then at the end of the craniotomy, you are usually using about 80 mics per kilo, 0.08 milligram per kilo morphine. That would be the best data out there for morphine. And if you converted that to fentanyl or hydromorphone and you take a consensus of most practitioners, they would give dural closure or 2 mics per kilo of fentanyl or 20 mics per kilo per minute of hydromorphone, and dural closure to the time of emergence being about 45 minutes. If you look at how does this provide anesthesia compared to evaluations of patient outcomes and also our surgeons, time to extubation for remifentanil is just consistent. We know that, although 20 and 30 minutes scares me. My surgeons wouldn't be happy if I did that long for my fentanyl-based craniotomies. And the time to follow verbal commands, again, remifentanil is just superior. The thing that is most interesting when you look at blinded observations by anesthesiologists and neurosurgeons for patient comfort, hemodynamic profile in the operating room, level of consciousness hemodynamic profile after surgery, and level of consciousness after surgery and overall quality in the first 12 hours, you find that the anesthesiologists and the surgeons both feel that remifentanil is superior to fentanyl when they're blinded. And there's no difference in the relationship of the opioid-related outcomes with remifentanil and fentanyl. So with that in mind, we say, okay, we're going to do an anesthetic. If we want to do what is classic now in the past 20 years, it's remifentanil-based anesthesia for intracranial surgery. I want to take a minute to talk about hypnotics, and to me that's, again, a chocolate chip or recipe kind of thing of what do you like. Well, we know that from, again, the Iowa group that had done the first fentanyl, alphentanil, sufentanil study, that we also know that propofol, isoflurane, and nitrous oxide used as balances with fentanyl actually had no difference in outcome. The time to extubation was close to each other. There was small differences that were not clinically different. And of course, as you would expect, the time to loss of consciousness on induction and time to orientation, the time to recovery of level of consciousness and time to orientation, the Aldrete scores, were a little bit better with the propofol and the nitrous and isoflurane, which is just kinetics. And any master clinician, if they weren't limited to a protocol, could probably overcome the statistical differences that they saw here. And this is what is repeat of what I just said. Any master clinician could find the time to following commands that they would be able to sit for the majority of intracranial surgery in that 10-minute mark, regardless of what hypnotic they used. These outliers are usually going to be patients who had also what the neurosurgeon did, affecting their level of consciousness or affecting their ability to follow commands. If you look at the next randomized controlled study about how do we choose our hypnotic, it's sevofentanyl versus sevo-remi versus propofol-remi. And pretty much it showed what we thought. If you titrate to a really nice recipe, if you want to say really fine-tuned recipe, you find no difference in brain relaxation scores and no difference in the time to the recovery of an Aldrete score greater than 9 in the recovery. And so it really shows you that all three, sevofentanyl, sevo-remi, and propofol-remi, are sufficient anesthetics to do intracranial supratentorial surgery. The interesting thing, of course, is that propofol gave you a less post-op nausea and vomiting, but the patients had no difference in their satisfaction scores. So now that we've talked about the classic anesthetic that we're doing is propofol or sevoflurane, desflurane, isoflurane, one of the modern, so-called modern halogenated agents, with remifentanil for the majority of neuroanesthetics, at least at the big academic institutions in the United States, we need to talk a little bit about what are the other options to add. So, as the previous speaker said, we need to think about what are we trying to do? We need to immobilize a patient from nociceptive responses, meaning if the patient gets poked with the incision and they don't have an adequate anesthetic level, they might reach up and actually try to grab the scalpel. Not a nice thing to do whether you're doing an awake or a sleep craniotomy. So we can use anti-nociceptive agents, and we can also use neuromuscular blocking agents. For hemodynamic control, we'll talk about anti-nociceptive agents and also use the antihypertensive agents in order to actually control the hemodynamic responses. The anti-nociceptive drugs, we just talked about the opioids. Dexmedetomidine will go over some of the data because it has some compelling place in the possible opioid-free or reduction of opioids in intracranial surgery. Local anesthetics is something we don't talk about a lot in intracranial surgery because it's a shared responsibility of the space with the surgeons, and some surgeons don't tolerate as nicely the time it might take or the ability it takes for them or us to place a scalp lock. But there are also data now on intravenous lidocaine for intracranial surgery. And finally, what we'll briefly touch on is there's some adjuncts you can add which won't or haven't been shown to decrease the amount of hypnotic or opioid used yet, and it hasn't been used in opioid-free anesthesia, but the gabapentinoids, clonidine, even COX-2 inhibitors and nonsteroidals have a place for the first two in decreasing the response to some of the nociceptive events at the beginning of the procedure, such as scalp fixation and also incision. And the gabapentinoids, clonidine, and the COX-2 inhibitors and nonsteroidals have a place for the analgesia afterwards. If you look at dexmedetomidine and comparing it to remifentanil, double-blinded controlled study randomized to Dexmed and Remifentanil, titrated dexmedetomidine after a loading dose to between an infusion rate of 0.3 and 0.7 mics per kilo per hour, and Remifentanil titrated between 0.05 and 0.25 mics per kilo per minute. You find that, not surprisingly, the mean arterial pressure control in the operating room, it's easier to control with dexmedetomidine, it's superior. The pain scores afterwards are less, and the morphine consumption is less. And so you see that dexmedetomidine has some place in intracranial surgery when compared to remifentanil. When you look at the reviews, a lot of the articles that were published on dexmedetomidine were not dexmedetomidine versus remifentanil. It was dexmedetomidine with an opioid versus a placebo with an opioid. And that makes it a little bit harder to say, can we replace remifentanil or opioids with dexmedetomidine? If you look at an opioid comparator, that's being remifentanil or fentanyl, you find that there was no difference in what they judge as procedural success, postoperative pain, postoperative analgesia use, intraoperative hypotension or hypertension, and intraoperative bradycardia. So dexmedetomidine in these few studies that were of moderate quality at best didn't seem to be sufficient, or it did not seem to be superior to opioids, but may be able to replace opioids. Scalp blocks, on the other hand, have some real data showing that they not only improve analgesia post-op, but also decrease a lot of the stimulation that you see in the operating room from the surgeons, and therefore can decrease your opioid and non-opioid requirements. The questions that we have to ask, and still haven't been asked, is does a local anesthetic contribute to sedation, which is probably not, but is always brought up by what dose of local anesthetic you need for scalp blocks, especially if you're doing bilateral scalp blocks to cover the entire cranium. What are the kinetics of onset and offset that we need to think about to provide not only at the beginning of the case the analgesia that we need and the anti-nociception that we need, but also at the end of the case the analgesia we need? Is 2-hour duration that is often quoted, but we don't seem to all think is really the length of our scalp blocks sufficient? The data to date show that morphine consumption may not change, although there's some small studies that are trying to disprove that. And the hemodynamics currently appear to be better if you have a scalp block, but not sufficiently so that anybody says, I need to replace my remifentanil or my other techniques with it. Finally, the question that is out there that nobody has looked at is Exparel, which is not approved in the United States for use for scalp blocks, but would a longer-acting opioid combined with a local anesthetic combined with a shorter-acting local anesthetic be able to make scalp blocks an important part of our methods of decreasing opioid consumption? IV lidocaine, on the other hand, has some data. These are data, I believe, from the Cleveland Clinic group showing that the pain scores after surgery with the patients who had, the number of patients who had a pain score 0 after surgery was significantly higher with lidocaine, and the pain scores stayed low in the lidocaine group compared to the control group. This was a 1.5 milligram per kilo load with 2 milligram per kilo per hour, which is a pretty standard loading dose that we also use in spine surgery. The data I did not show is that the time to extubation and the sedation that were reported were similar between the control group and the lidocaine group. So if we're going to do intracranial surgery without remifentanil, what do we need to think about? When I actually think about this, and this is a slide I have from a while ago now, when I thought about why remifentanil has really emerged as part of my armamentarium, it's because of this, transcranial motor evoked potentials. If I'm using transcranial motor evoked potentials, which some institutions do for intracranial surgery, I pretty much use remifentanil. It's partly because it's titratable, partly because I need something that's anti-nociceptive that I can guarantee will provide me the ability to have a rapid emergence, but also no movement to whatever stimulation is provided in the operating room. If I'm not doing transcranial motor evoked potentials, then I look at how is the preoperative cognitive status. If the patient is preoperatively cognitively impaired sufficiently, I start thinking about using remifentanil. Even for my VP shunts, I actually will be biased to use remifentanil for those patients who have a cognitive hit from the acute increase in intracranial pressure. If they don't have that cognitive hit, if they're actually talking and walking and functional except for whatever is their I should say, whatever there's a focal lesion is causing them, then I start thinking that I might be able to avoid remifentanil. When I do skull-base surgery and posterior fossa surgery, I often will go the other route and use remifentanil. If I'm not doing skull-base surgery and posterior fossa surgery, and I'm not doing motor evoked potentials, and my patients are cognitively, preoperatively intact, really there's a place for non-opioid anesthesia now. Have I emerged to doing that consistently yet? Not yet. But we'll talk in a second about what options I am playing with and what options I see in the literature. Skull-base surgery, I still, like I said, I'm biased in posterior fossa to using remifentanil because I often use total intravenous anesthesia, but my surgeons at 3 of my 4 previous institutions were heavy on the motor evoked potentials for those patients. I don't think there's enough literature to say that you have to, but when people tend to run propofol intravenous anesthetics in the United States without target control infusions, they tend to use remifentanil. I think in a lot of the European countries and Asia where they have target control infusions, you start seeing people use Sufenta or fentanyl instead of remifentanil if they're not doing motor evoked potentials. But in a lot of the skull-based surgery, we're using EMG monitoring and compound muscle action potentials as a direct stimulation of the facial nerve, so you cannot use your muscle relaxant. What is my anesthetic dream if I weren't going to use remifentanil and I could use muscle relaxant? Propofol in a low dose. I actually go as low as 40 mics per kilo per minute propofol when I use remifentanil because it's such an efficient hypnotic. Rocuronium, so Gamodex has changed the game that I think you can go profound neuromuscular blockade and then reverse them predictably. The non-opioid anti-nociceptives, dexmedetomidine, lidocaine infusions, scalp blocks, pre-pinning, and then thinking about doing, again, a supplement post-closure. IV acetaminophen has become part of what I use at the beginning and middle of intracranial surgery. And then what's the role of esmol, clofidipine. Dexmedetomidine and lidocaine, the biggest problems I see is how do you actually put the two of them together without having prolonged wake-ups? Is there additive at minimum or are they synergistic with propofol? And are you going to find yourself that as you add one and then the next that your surgeons will not tolerate that 15-minute wake-up as you're learning how to titrate these drugs? So in summary, the truth I would say about remifentanil is it's not essential for most neurosurgery, intracranial surgery. I know 15, 20 years ago, people would be shocked if I said that. I think that if you can't use neuromuscular blockade or you have poor cognitive function, remifentanil has a really important role. I like to say that the cost of a CT scan is a lot more than the cost of the remifentanil used if you average a milligram an hour. Remifentanil guarantees immobility from all the nociceptive inputs, especially if you run it on the higher side. And it has the most predictable emergence characteristics of all the anesthetics that we currently have available for general anesthesia. If you can use neuromuscular blockade and they have good preoperative cognitive function, then a non-opioid anesthetic is really feasible. And I think that's where we need to start looking at what data are missing. Well, the interactions, like I said, and as a clinical pharmacologist, this is something I think about a lot, but how does dexmedetomidine now interact with either propofol or volatile anesthetic as I'm giving it? How do I get good at titrating dexmedetomidine? Because remifentanil was so easy to titrate, you had a lot of ability to overdose and be forgiven. Whereas dexmedetomidine, we all know of a case where it took 35 to 45 minutes for the patient to wake up when you're used to having 10-minute or less wake-ups, and so you're just tapping your feet and just kind of, oh gosh, what should I do? Lidocaine, I think, is a little bit more benign, but that's not proven in the literature. It's just we all have that feeling. Ketamine, I think, is the drug we haven't talked about yet, but is starting to emerge in the traumatic brain injury literature, not only as a possible field agent for battlefield and frontline anesthetics, but also for its possible neuroprotective activity. But ketamine has even less predictability in its emergence characteristics, and so adding that to dexmedetomidine and lidocaine has the quandary of which one do I blame when the patient doesn't wake up? If I had intrathecal methylphenidate like they do for the rats in Mass General, I can reverse my propofol and probably wake up anybody. Max Keltz might have some other ideas of what he can do to wake up fruit flies in the rats he has, but I can't do any of that to my patients, even with an EVD. The anti-nociceptive agents versus antihypertensives, the stress response is probably the biggest thing that we don't know about right now. We know that there's some data showing that you get an increased stress response if you use antihypertensives like Esmol or clozapine or nicardipine or even nipride in place of an anti-nociceptive. And so is that stress response something that's bad? Are those catechols, if you control the hemodynamic consequences, still a problem? And finally, Esmol versus clozapine, very too titratable, very too forgiving drugs that have Remifentanil-like kinetics, but is there a benefit of beta-adrenergic? Does it have some not yet proven but suggestive of analgesic properties in its own right, or is using a calcium channel blocker itself a reasonable thing to do? So with that in mind, I'd like to invite the panel up here so we can take questions from the audience about opioid-free anesthesia and broadly and also neurosurgical applications. Thank you.